Hello.
Hello, sir.
Yeah. Hello. Sangeeta Priya.
Sir, good evening, sir.
Can we start, Doctor?
Yes, sir.
Yeah. Madam Balashnan and Sanjoy, can we start?
Yeah.
Yeah. Yeah.
Okay,
Yeah.
sir.
Yeah.
Good evening, sir.
One second, Doctor. One second. Let me introduce the speakers. Good
Hello,
evening
ma'am.
and welcome. Yeah. Good evening and welcome you all for this evening. The one another neurological case discussion by our postgraduate Dr. Sangeeta Priya from Department of Medicine, PhD, IMSR. To discuss this case, we have with us Dr. Balakrishnan, a professor and head of the Department of Neurology from PhD, IMSR. Really like to thank you, Dr. Balakrishnan, for accepting our invitation, being the faculty for this evening. And we have Dr. Sanjo John, who is the assistant professor in the Department of Neurology from PhD Institute of Medical Science and Research. Yeah, really thank you, Dr. Sanjo, for being the faculty for this evening. Over to Dr. Sangeeta Priya for presentation and Dr. Balashnan and Sanjo to take over the further proceedings of this session. Thank you.
Okay, sir.
Thank you, sir. Good evening, respected professors and all my PG friends. Today I'm going to present a case on CNS system. He's a 73-year-old male hailing from Pondicherry, studied up to BE. Occupation is a retired executive manager in PWD, right-handed individual. His informant is his son, who is reliable and his reliability is good. He presented with chief complaints of difficulty in using his both lower limbs for the past 10 days, low back pain for the past 10 days, and right knee joint swelling for the past 10 days. History of presenting illness, patient was apparently normal 1 year back. Slowly, he developed neck pain and difficulty in using his right upper limb and left upper limb in the form of holding objects, difficulty in using his right hand for writing, mixing of the food, and using left hand for the toilet purposes, and also raising the arm above the head. There was no history of any difficulty in using his lower limb at that point of time. He was diagnosed as a case of cervical spondylosis and advised conservative management for the same. Patient currently was staying at an old age home. 10 days back, he had a slip and fall and sustained injury to his bladder, following which he was confined to bed. At the time of the fall, there was no history of loss of consciousness, bladder and bowel disturbances, and involuntary movements. Immediately post-fall, he recognized that he was not able to move both his lower limbs. He was not able to sit without support. Patient attenders noted flailness of both the lower limb while attempting to shift him to the nearby hospital. Patient had a severe low back pain post-fall, which was not radiating and aggravated on movements. Post-fall, the attenders noted right knee joint swelling, which was not associated with any bleeding or open wound. Patient was shifted within a duration of 1 hour to a nearby hospital at Pondicherry. After receiving in the emergency department in the hospital, they found that his bladder was distended and hence he was catheterized. Spine imaging was taken, the records of which was not there, and stabilized at Pondicherry itself, from where he has been referred to PSD for further management on next day. On receiving here, he was advised to get opinion in ortho OPD for the above said complaints, during which the patient went for a sudden cardiorespiratory arrest and his ROIC was achieved with 5 cycles of CPR and then he was stabilized. The reason for this sudden cardiac arrest was attributed to his previous illness, as he is a known case of coronary artery disease for more than 8 years. He had a history of difficulty in using his hands for holding object and difficulty in buttoning and unbuttoning using his right hand, history of difficulty in mixing the food, history of difficulty in using his left hand for toilet purposes, and history of difficulty in raising hand above the shoulder. He had a history of thinning of hand muscles, no history of twitching of muscles, no history of cramp or involuntary movements, history of difficulty in lifting head from the pillow, history of difficulty in turning and rolling over in bed. There was no history of diurnal variation of weakness or no history of easy fatigability. He had a history of difficulty in appreciating hot and cold water while sponging below the neck level, not able to feel the cloth sensation below his neck. History of neck pain present, which is a sharp shooting pain radiating to both the shoulders, which aggravates on the neck movement. There was no history of any tingling or burning sensation. He is able to perceive the smell of food. No history of blurring of vision or no history of difficulty in differentiating colors. No history of drooping of eyelids or double vision. There was no history of difficulty in moving eyeballs in all directions. Able to chew food without difficulty. No history of loss of sensation over the face. Able to close his eyes while sleeping. No history of drooling of saliva, deviation of angle of mouth, or loss of taste sensation. There is no history of hard of hearing, tinnitus, or vertigo. No history of difficulty in swallowing, nasal twang, or nasal regurgitation. There was no history of hoarseness of voice or no history of difficulty in shrugging the shoulders. He is able to roll the tongue and push the foot backwards. He is not able to feel the bladder fullness, and he had difficulty to initiate micturition and void. There is history of constipation, no history of any palpitation or abnormal sweating, no history of any postural giddiness, no history of spillage of food and water, no history of smashing and smearing of food while over the face while eating, no history of any speech disturbances, no history of any involuntary movement, no history of fever, projectile vomiting, and blurring of vision. There was no history of emotional lability, no history of seizure, no history of delusion and hallucination, no history of any recent vaccination, no history of abdominal pain or cough with expectation, no history of loss of weight and appetite. Past history, patient, a known case of diabetes for the past 50 years and is on medication, known hypertensive for the past 20 years and on regular medication, is a known case of coronary artery disease, status post CABG 7 years back and is on single antiplatelet. He underwent for BPH 2 months back. He was diagnosed as a case of cervical spondylosis 1 year back and on conservative management. Not a known case of bronchial asthma, thyroid disorder, seizure disorder, tuberculosis. He was vaccinated for COVID 3 years back. Personal history, not an alcoholic, smoker, beetle nut chewer, bladder and bowel disturbance present, sleep and appetite normal. Family history, no significant family history. Summary.
Can we go to that history of
73 years.
presenting illness once again? Doctor,
Yes, sir.
can we go to
Yes,
that
sir.
history of presenting illness once again?
Yes, sir. Yes, sir. Yes, sir.
So first, what was the complaint with the patient was having initially?
Sir, present complaints 10 days back, he had a slip and fall, sir, and he sustained injury to the back.
Okay.
So that time,
Okay.
current presentation is he's having difficulty in using his lower limb. Before 1 year, he had difficulty in using his upper limb for day-to-day activities in the form of difficulty in mixing food, buttoning and unbuttoning, or holding objects. Sir.
So the thing
So
is
he
of
had
previous history, you are telling of your mixing up of all both the past and whether you have to consider it in past history or you have to consider it in a presenting illness. Now with the presenting illness, you are starting with the history of fall with paraparesis. I mean that the patient is having difficulty in using lower limbs. So
yes, sir.
if you're considering from that past history, so whether past history in the sense you are complaining of a cervical spondylosis changes. So whether it is
Yes,
a
sir.
symmetrical or asymmetrical, you are combining both now. So whether it was symmetrical in onset or asymmetrical in onset.
Sir, this patient 1 year back, he was diagnosed as cervical spondylosis, asymmetrical, sir.
So cervical spondylosis, but the patient was having weakness of both hands, no? So
Both the hands,
and you
distal
are
and proximal involvement. Yes, sir. It
yeah,
start
and
like
you mentioned the
he was
mainly
not
in the
able
right
to.
hand, no?
That history was not clear, sir.
Okay, and it was in the more in the right hand or in the both hand the patient was having, and the history was not clear actually. Okay, and
Yes,
after
sir.
that
Yes,
for the
sir.
10 days there is a history of slip and fall, followed by initially with the patient was noticed to have weakness of both lower limbs. Am I
Yes,
correct?
sir. Yes, sir. With the loss of
Okay,
sensation and the
along with
bladder
the
involvement, sir.
okay, whether this bladder involvement was early bladder or late bladder involvement.
Sir, earlier, sir.
Early or late bladder involvement. Early or late bladder involvement.
Sir, it is an early bladder involvement, sir.
Bladder involvement was in that early bladder involvement. So,
Yes, sir.
okay, and early bladder involvement with the symmetrical onset of weakness of both lower
Weakness of.
limb associated
Yes,
with the
sir.
slip and fall.
Yes, sir.
So, what are the things you try to consider at this point of time?
Sir, following fall, the patient would have got injury to the spinal cord, sir, lower spinal level can be a possibility. And because of the bladder involvement, the localization can be in the spinal cord, sir.
Okay.
Then
Spinal cord, because of the patient is having weakness along with that bladder involvement, you want to localize to spinal cord
spinal
as
cord,
it is
yes,
an
sir.
acute in onset. Am I
Acute
right?
and
Okay.
onset can be a vascular event also can be a possibility, sir. Like
Vascular
spinal artery thrombosis.
acute onset, you are telling of acute onset, but there is a history of slip and fall, no?
Yes, sir, yes,
And
sir.
with
No,
that
sir,
fall history only, the patient you are attributing to the fall history, no?
yes, sir. Yes, sir. Following fall, it can be due to trauma leading to the injury of the spinal cord at that level, sir, and leading to both lower limb paraplegia with the bladder involvement, sir.
So if there is a lower limb paraplegia with the bladder involvement,
Yes, sir.
what can be the cause of this lower limb paraparesis with the bladder involvement? Where can be the lesion for the patient? Where all you can expect a lesion?
Sir, conus cauda equina.
Okay, what is cauda equina?
Sir, cauda equina, it is the nerve roots starting from L3 and below, all the nerve roots can be involved, sir. From L3
Okay.
and multiple
So
nerve
in
roots.
cauda equina, okay.
It
Okay,
will be
so
actually
L3 is there
unilateral.
then,
It will be unilateral, sir,
okay,
and asymmetric. But more severe
it
pain will
may
be
not,
there, sir.
it may be bilateral, bilateral also. It
Okay.
may be asymmetry associated with the pain.
Yes, sir. Associated.
Cauda lesion
Yes,
can be.
yes, sir.
Okay. You told of complete paraparesis or paraplegia.
Yes,
So
sir.
what are the hip flexors? What is the root value of hip flexion?
L1, L2, sir.
But the cauda falls below L1, no?
Yes, sir. Yes. Sir, it can be a combination of conus and cauda also, sir, sometimes in the case
Okay,
of
conus
trauma.
and cauda. Okay, fine.
Conus.
So, okay, conus and
Okay.
cauda.
Cauda.
So
So
if,
if it is in that case,
okay,
there can be involvement of L1, L2 levels.
okay. What about the bladder control? You want to tell about UMM bladder or LMN bladder?
Element bladder, sir. Because the patient had loss of sensation and he had difficulty to initiate and also to void, sir. So according
Hello.
to the history, when the patient presented to the emergency department, he had a distended bladder, sir, which was catheterized and
Okay.
more amount of urine was drained out, which is more likely of voiding problem and it attributed to element type of bladder involvement, sir.
Okay. What are the spinal segments that controls the bladder?
Sir, at the level of spinal cord, sacral level, S2, S3, S4, and on-off nucleus, sir.
Okay, okay. Okay, you proceed.
Okay.
And after that, the patient presented with acute onset of paraplegia along with that bladder control
Yes,
was
sir.
lost. And after that, any other positive history other than that?
Sir, no positive diseases. He had a sensory loss, sir, like not able to appreciate the hot and cold sensation. And in the neck, he had, like on flexing the neck, he had a sharp lancinating like type of pain, sir, which is suggestive of Lermity sign, sir. Other than that, no other cranial nerve involvement or no
Okay.
other
My doubt
cerebellum
is
involvement.
this Lermity sensation you are pointing and this weakness you are pointing out, whether it was this Lermity sensation was present before the fall or after the fall on.
Sir, even before he was having the TST, sir.
Okay, okay. So
Even before the
that you are
fall, he was
attributing
having
to the
this.
previous cause.
Yes, sir, previous, sir, not the current ones.
Okay, okay. So current one is you are telling about acute onset of paraplegia with involvement
Yes,
of
sir.
bowel and bladder.
Bowel and bladder, sir.
Okay, okay. You proceed.
Okay.
Okay, you proceed with summary.
Okay, sir. Summary, 73-year-old male is known diabetic and hypertensive coronary artery disease, BPH, with the symmetrical upper limb weakness with thinning of muscles and neck pain, now presented with recent history of fall, followed by bilateral symmetrical lower limb flaccid paraplegia with element type of bladder involvement with the loss of sensation without involvement of cranial nerve, cerebellum, and extrapyramidal structures. The probable structures involved are bilateral corticospinal tract, bilateral spinothalamic tract, bilateral posterior column, element bladder with bowel. The anatomical localization is spinal cord, cervical region. For this patient, I want to attribute the problem at two levels, sir. One is cervical. The probable etiology is degenerative because of the ages and changes of cervical changes like spondylitic myelopathy. Another is at the lower level, which is due to trauma, probably extramedullary, extradural, post-traumatic compression involving cauda equina, sir.
Okay, regarding the bladder symptoms, can
Yes,
you
sir.
tell about what all the storage symptoms you will ask in history, or you will concentrate in history? Storage related symptoms or voiding related symptoms?
History of urgency, sir, and frequency.
Okay.
That is for the UMN bladder, sir. For element bladder, there will be a difficulty
No, no,
in
no. I am asking about, yeah, that is
uh,
UMN and LMN. You can ask about this UMN versus LMN. First, you tell about UMN versus LMN. Then you elaborate about storage symptoms or voiding symptoms. Okay, you tell about UMN. You told about urgency.
Urgency, frequency.
Okay.
Then lower. Then element. It is about difficulty in
Only urgency,
perception.
frequency, or hesitancy. Actually, in UMN
Hesitancy, sir.
bladder, there can be urgency can be there, frequency can be
Okay,
there, and
sir.
hesitancy can be there, and
Oh, sir.
multiple voiding episodes, double voiding,
Okay.
or patient can have multiple voiding episodes can also be present in UMN kind of bladder.
Okay, sir.
So what in spinal cord you consider as a UMN type of or spinal bladder? What level do you consider in a spinal cord?
Sir, infrasacral, sir.
Suprasacral,
Usually,
infrapontine.
infrapontine, suprasacral and infrasacral.
Suprasacral infrapontine. And we use
Yes,
the
sir.
term detrusor
Sir,
sphincter
UMN,
dyssynergia.
UMN it is infrapontine suprasacral, sir. For LMN it is infrasacral.
Yeah. And in that UMN bladder or spinal bladder, you tell about detrusor sphincter dyssynergia. Because
Yes,
of
sir.
that only the patient is having. Yeah. Dyssynergia
Yes,
patient is having. And you told about LMN bladder symptoms. What are the LMN bladder symptoms you point out?
they have this hesitancy and interrupted stream, sir. Then overflow incontinence.
Okay.
Residual urine will be present.
Okay.
They
Why
won't
can't it
completely, they
be
won't be able
the
to complete.
same?
So,
Okay. This patient present with sudden onset of paraplegia along with the bladder symptoms.
yes, sir.
Why can't it be a spinal bladder with a dorsal myelopathy lesion?
Dorsal myelopathy, sir.
Yeah.
It can
If there is any
possibilities.
lesion at a dorsal level, thoracic level.
Possibilities
Because
can
patient
be,
can
sir.
present with
If the
paraplegia.
injury is at the level of, sir.
No, you continue. You tell me.
On general examination, patient conscious, oriented to person, time and place, afebrile, poorly built and nourished, height is around 167 centimeter, height neck ratio is 13, no pallor, icterus cyanosis, clubbing, lymphadenopathy and pedal edema. There is no neurocutaneous markers or no markers of HIV, tuberculosis and syphilis. Arcus senalis present, bilateral immature cataract, no peripheral nerve thickening, thyroid and examination was normal. Vitals, pulse 88 per minute, regular in rhythm, normal volume, no specific character. All peripheral pulses are felt equally. No radial delay or radiofemoral delay. No vessel wall thickening, no carotid bruit. BP 110 per 70 mm of mercury measured in right arm in supine position. Respiratory rate is 18 per minute. Abdominal thoracic type of respiration. Temperature is afebrile. JVP not elevated. SpO2 is 98. Single breath count is 20. CNS examination, higher mental function, patient conscious, oriented to time, place, and person, speech, fluency, repetition, comprehension, intact, Language, naming, reading intact. Mood and effect normal. Memory is intact. No deletion or hallucination. MMSC is 24. Cranial nerve examination. On examining on the right and left side. First cranial nerve. Sir?
Excuse me, patient is literate or illiterate?
Sir, I'm
MMSC
not
24,
able.
no? Patient is
Uh, Sir, it
literate
is.
or illiterate?
Sir, he is literate, sir. He has studied BE, sir.
Okay, fine. For BE studies 24, whether you consider it as normal?
Sir, actually 30 is a normal thing, sir. Up to 24, we can consider it as normal, sir. If it is less than 20, it is moderate cognitive.
No. If it is a graduate, he is a graduate, no? More than 27,
Yes,
it has to come, no?
okay, sir.
Okay, fine.
Okay. Okay. Cranial nerve examination, right and left. First cranial nerve, sense of smell, normal. Second cranial nerve, visual acuity 6/6. Field of vision, normal. Color vision, normal. Fundus, pale background is present on right and left. AC media was present. Third and fourth, sixth, there was no ptosis, no nystagmus, both right and left. Sackets is normal.
Doctor,
Pursuit smooth
what
and
are the
full.
importance of, excuse me, what are the importance of
Yes,
cranial
sir.
nerve examination in spinal cord lesion?
Sir, in case of non-compressive myelopathy, sir, we have to look for optic nerve, second cranial nerve, and in case of high cervical cord lesion, we have to rule out low cranial nerve palsy, sir, involvement of lower cranial nerve.
I'm just in the optic nerve. I'm
Then-
asking about what are the causes of optic nerve. Now, if you are,
Then-
because your patient is having spinal cord lesion at multiple levels.
Multiple sclerosis,
There
we
is
have to.
Okay, multiple sclerosis. So multiple
And NMO
sclerosis can
spectrum.
have skip lesion. Okay.
Yes, sir.
So in between NMO spectrum and multiple sclerosis, how the spinal cord lesion differs? In patchy involvement can be more in NMO or multiple sclerosis?
Multiple sclerosis, sir. Patch involvement is seen in multiple sclerosis. Dissemination in space and time is more common in.
Yeah, that is disseminated in space and time. Okay, McDonald's criteria. And
Okay,
but the thing is, central part of the cord or peripheral part of the cord and the transverse section of the cord, spinal cord, how it affects between MS and NMO?
Sir, in NMO, there will be centrally located as lesion and multiple sclerosis peripheral lesions. Sir?
Yeah, the transversely, yeah, what you told is okay. MS is peripheral located and NMO is centrally located. And the scattered lesions can be present in multiple sclerosis and longitudinal extensive lesion can be present in NMO.
LD, yes, sir. NMO, yes, sir.
Regarding, you told about conus, coda, and the conus. If you are suspecting a conus lesion and suspecting a demyelinating pathology, out of this MS, NMO, MOG, anything can be possible, which is more likely if there is a conus lesion is there.
Among this multiple sclerosis in NMO, sir? These two are so.
Among multiple sclerosis, NMO, MOG,
Yes, sir.
you have given 3 options. Out of this 3, if you are having a conus lesion, which word do you, and you are suspecting a demyelination, which will be more likely comparatively?
Sir, MOG, sir, conus lesions are more.
Yeah, MOG can have more of the conus lesion is most present in MOG, and chiasma, where you can get optic chiasma involvement. How the optic nerve involvement is present differ between NMO, MOG, and optic neurite, means multiple sclerosis.
Optic chiasma, sir.
No. Regarding the optic nerve involvement, how the demyelination differs between MOG, NMO, and multiple sclerosis.
Sir, bilateral involvement in case of NMO, sir. Then
MOG, there is no bilateral involvement.
Sir, MOG.
MOG, there can
but
be
MOG is also
bilaterally.
Yes, sir, involvement. Multiple sclerosis alone, there is focal.
Okay, multiple sclerosis can have unilateral or patch involvement can be present.
Patch involvement, yes, sir.
Anteriorly in the bilateral optic nerves. MOG can
Okay,
present
sir.
more posteriorly and involving the optic chiasma can be present.
Okay, sir.
Involvement.
Okay, sir. Okay, sir.
Okay. That is regarding the optic nerve. Any other
Okay, sir.
lesion, whether any other etiology, whether you suspect if you got a patient with the bones or with along with the spinal cord pathology. If and you told about non-compressive patterns. Any other
Yes, sir.
non-compressive things you can think about, MOG or any other thing. If you are having any eye lesion.
Eye lesions.
Tuberculosis.
Okay, sir. Tuberculosis, yes, sir. Choroid retinate. Choroid.
Sarcoidosis also can present with a mass.
Okay,
Mitochondrial
sir.
can have multi-axial can be present.
Sir,
Okay.
vitamin B12 deficiency, sir.
Vitamin B12 deficiency also can present. So vitamin
Yes,
B12
sir.
is a non-compressive. So
Yes, sir.
what are the involvement can be present in vitamin B12? What do you tell about vitamin B12 in cord? If there is involvement is there, what do you
Posterior
tell
and
that the
lateral, posterolateral cord involvement will be present. Yes, sir.
present? What about corticospinal tract or pyramidal involvement? Hello, am I audible?
Yes, sir. Sir, it will be involved, sir.
What about? Okay, so 3 P's we can tell about 3 P's. One is pyramidal,
Pyramidal
one is
tract,
posterior column,
posterior column, yes, sir. Posterolateral.
and peripheral nerve. It's cord, these two
Yes, sir.
things, and peripheral nerve. Okay,
Peripheral nerve.
fine.
Okay, sir.
Okay, you can proceed.
Okay, sir.
Or any
Trigeminal
other questions or something?
Shall I proceed, sir?
Yeah.
Trigeminal nerve, sensation over the face, normal on both right and left. And the action of masseter temporalis pterygoid was normal. Corneal and conjunctal reflex intact, present on both the sides. Facial
Okay,
nerve
what is the
motor, there
importance
is
of trigeminal nerve involvement and spinal cord pathology? Can you
yes,
get
sir,
a
because of
trigeminal involvement?
yes, sir, because of the spinal nucleus of the trigeminal nerve, sir, there will be
How long it
involvement of
will
sense.
extend?
Sir?
How long it
How
will
long?
extend this trigeminal nerve, that nucleus, how long it will extend? Whether it will extend up to spinal cord level or not, or it will end in
Yes.
brainstem level only.
Cervical cord, sir. Yes, sir, it will extend.
So high cervical cord lesion, you will get a trigeminal involvement can be present.
Yes, sir.
Okay,
Sensory involvement from the peripheries and onion-like pattern involvement of sensory involvement will be present, sir.
Okay.
Spinal nucleus.
Okay. So onion-like pattern from below upwards, if it is there. If it is below upwards, you will get onion-like pattern, whether it is the outer part involved first or whether it is a central part involved first.
Outer part is involved first,
Okay.
sir.
Okay, fine. Please proceed.
Yes. Facial nerve, wrinkling of forehead, normal. Closing of eyelid against resistance, normal on both the sides. Nasolabial fold, normal. Not obliterated. Blowing of cheeks, able to do. No, there is no angle of deviation of mouth. Taste sensation over the anterior two-third of the tongue, normal. Vestibular cochlear nerve, Rennie's test, right side air condition more than bone conduction, left is air condition more than bone conduction. Weber's test not lateralized. Glossopharyngeal and vagus nerve, uvula and midline, palatal movements normal and equal on both the sides, gag reflex intact. Spinal accessory nerve, shrugging of shoulder normal, movement of the head side to side present but restricted because of his neck pain. Hypoglossal nerve, tongue tone normal, bulk normal, wasting fibrillation, there was no wasting in fibrillation. On protrusion of the tongue, there is no deviation. Going to the motor system examination, attitude of the patient in supine position, bilateral upper limb, shoulder adducted, elbow slightly flexed with wrist at position of ease. Small muscle wasting is present in both the hands, thenar and hypothenar wasting present. Flexion deformity at distal interphalangeal and proximal interphalangeal joint of right middle finger present. Bilateral lower limb adducted at hip, knee extended and ankle at position of ease. Bulk on inspection.
What will be the attitude? One more, doctor. What will be the attitude of the patient if the corticospinal tract is involved?
So, which tract, sir?
If corticospinal tract, pyramidal tract is involved, what can be the attitude of the patient?
Sir, it will be at the shoulder, it will be adducted, sir. Then
Okay.
elbow flexed and wrist is also flexed, sir.
Okay. Lower
Then
limb.
lower limb, hip adducted, knee extended, and the plantar will be flexed, sir.
Lateral rotation. Okay. Lateral rotation.
Okay, sir. Sir?
And plantars will be flexed in dorsiflexed or plantar flexed? Ankle.
Plantar, sir.
Ankle position, dorsiflexed or plantar flexed position? Flexion, or you will tell dorsiflexion or plantar flexion, no?
Sir, I said plant at the
Plantar
level
flexion.
of the
No, we're
ankle,
telling
it
about
will be
flexion.
at the level of the ankle, there will be plantar flexed, sir.
Okay, okay. Okay, okay, fine. Proceed.
Okay, sir.
Ma'am,
Then
any other
wasting is,
question, ma'am?
sir, shall I proceed, sir?
Yeah, you proceed.
Okay, sir. Wasting in the arm and forearm present on the right and left. Thenar and hypothenar wasting present. Dorsal interdorsal wasting present in both the hands. Tone upper limb, it was hypotonia on right and left, and lower limb, it is hypotonia. This is the presentation of the patient while receiving in the hospital. Right hand, the left hand, there is prominent thenar wasting, and there is a flexion deformity of the middle finger. And in the last picture, there is a guttural wasting, which denotes the interosseous muscles, or guttural picture, which is also denotes the interosseous muscle wasting.
So this patient is having thenar wasting present for the patient, and he's having
sir.
some UMN findings and LMN findings present.
Yes,
So
sir.
you told about degenerative cause of etiology, that is spondylosis changes. Can
Yes,
it
sir.
be ALS?
Sir, other symptoms like fasciculations.
Okay. Here, in spinal cord level, if it is
Okay.
a single lesion, UMN finding is above the LMN finding, and the patient is not having fasciculation. Patient is not having fasciculation, but the patient is
Fasciculation,
having
sir.
some wasting, thinning, you told, no? And thinning,
Yes, sir. Yes, sir.
and the patient is
Thinning of the
having
muscles, wasting.
thenar more.
Sir, but
Tell
in
about if there is
ALS, there won't be no bladder involvement and sensory involvement.
yeah, bladder involvement is not present, and extraocular muscles also not involved in ALS. Here also there is no extraocular muscle involvement, and there is no
Sensory
tongue
involvement is
fibrillation.
also
You
not.
told about tongue exam.
Yes, sir.
Sensory involvement is not present in ALS.
Will not be present
So
in. Yes,
no,
sir.
I just asked a question on it because there is a human finding about the element finding, but the patient is having two different findings at two different point of time. There is a gap between, you are attributing
Yes,
it
sir.
to the two different lesion.
Yes,
So
sir.
I just told about that. What about
Okay,
split
sir.
hand syndrome and reverse split hand syndrome?
Split hand syndrome, it is seen in the ALS, sir. Reverse split hand is seen in Hirayama disease, sir.
What is split hand syndrome?
Sir, the thenar eminence muscles will be involved more than the hypothenar muscle involvement. That is split hand sign, sir. That is the base of the thumb and the first dorsal interosseous muscles that will be wasted more, sir. When compared to the little finger wastage,
Hypothenar
which is
wasted more than thenar in reverse split hand.
yes,
Hypothenar
sir.
wasted more than thenar in reverse split hand, that is
In
present in Hirayama.
yeah,
Okay, so
yes,
what
sir.
are the thenar muscles?
Opponent's
What are the
pollicis
thenar
brevis,
group
sir.
of muscles?
Abductor pollicis brevis,
Hmm.
opponent's pollicis brevis, and adductor pollicis brevis, sir.
Okay. Adductor, it is abductor, flexors, and opponents.
Flexor
Adductor
pollicis
pollicis
brevis
is
and
adductor, flexor, and opponents. But adductor pollicis is supplied by which nerve?
Ulnar, sir.
Okay. Rest of what you told of abductor, flexors, and opponents are supplied by?
Medial nerve, sir.
Okay. 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 You continue.
Measurements: right, left, upper limb, arm, it is 22 centimeter, and forearm 20 centimeter from the above the medial epicondyle and the olecranon process. Then the left upper limb 23 in the arm and 20 centimeter in the forearm. Lower limb 18 centimeter above the patella, it is 35 centimeter in the right, and the left it is 36. And the 10 centimeter below the tibial tuberosity is 30 centimeter in the right and 30 centimeter in the left. Power, shoulder, flexion, extension, adduction, abduction, right side and left side, it is 4/5. Elbow, flexion, extension, it is 4/5 on right and left. Wrist, flexion, extension, 4/5 on the right side and left side. Finger, flexion, extension, abductor and adduction, 3/5 on both the side. Hand grip, 60% on the right and 60% on the left. Hip flexion, extension,
My
abduction.
doubt is, 1 minute, Sangeeta. The
Yes,
upper limb you told about all are symmetrical, no? But the patient was
yes,
having
sir.
some answer you told in history of presenting illness, some right limb, right upper limb. Specifically, you told of some weakness in the right upper limb, no? Both upper limb that was there, and mixing of food was there, and right upper limb was there. But
Left
the
also. Yes.
yeah, but the weakness is symmetrical in upper limb also, because it showed that picture of small muscles of hand, and one
Yes,
there was a hypothenar wasting mostly more compared to the other, and one had a thenar wasting compared to the other, and there was interosseous wasting was also present. But here the power is almost 4-5. In we have to tell about the power of all joints specifically, if it is flexion, extension, if there's any difference, because you pointed to a corticospinal tract involvement. If it is a corticospinal tract involvement, there's a pyramidal pattern of weakness will be there. This is not a pyramidal pattern of weakness. This everything is affected symmetrically. It is not that particular group of particular movement is not affected. Usually pyramidal pattern in upper limb is abduction will be affected. Extension at the abduction at the shoulder, extension at the elbow, and then extension at the. So it will be more affected compared to the rest of the movement. So it is not following that pyramidal pattern. In summary, you told of corticospinal tract, most common structures involved of corticospinal tract. So if the weakness is and the patient is having a lemon bladder, why can't it be a peripheral neuropathy or kind of things?
Peripheral neuropathy, there is a possibility.
Told about tone for this patient, and what you told about tone for this patient, upper limb and lower limb.
Lower limb is hypotonia, sir.
Upper limb?
Upper limb is hypertonia, sir.
Hypertonia. Hypertonia, what are the hypertonia? Whether it is rigidity or paratonia?
Sir, it is spastic, sir.
Spastic. So you are pointing towards a UMN kind of lesion involving the corticospinal tract. You are pointing towards that only, no?
Yes, sir.
So
Yes, sir.
UMN,
Sir, you.
is
I'm not
having
able to use.
No, pyramidal pattern of weakness is not followed here actually. Am I audible?
Yes, sir. Yes, sir. No, yes, sir.
Yeah, and finger grip is also bilaterally, it is coming of the same similar pattern only. So that if you're pointing to a corticospinal tract, that it is not that pattern is not that much visible in that examination part. Okay, you proceed.
Okay, sir. At the level of hip, the flexion, extension, abduction, adduction, internal rotation, external rotation, both on the right and left, the power is 0/5. Knee extension, flexion, 0/5 on both the side. Then ankle, dorsiflexion, plantar flexion, inversion, 0/5 on both the sides. Toes, flexion, extension, adduction, abduction, 1/5. Reflexes, superficial, corneal, conjunctival.
Of the ankle? The everters at an angle joint, what are the muscles causing eversion?
Evertus, sir.
Everters. What are the inverters and what are the everters?
Sir, peroneus, longus, brevis.
Peroneal muscle will cause inversion or reversion?
Eversion, sir.
Okay. Inversion by?
Inversion tibialis anterior and tibialis posterior. Sir.
Dorsiflexion by?
Dorsiflexion, extensor hallucis longus of the great toe, sir.
Okay. And what are the hip
Then,
flexors?
so
Can you tell
tibialis
about the hip?
extensor digitorum longus for the other fingers, sir.
Okay. What about the hip flexion? Hip flexors, muscles causing hip flexion?
Yeah, iliopsoas is a major muscle of hip flexor, sir.
Okay. Okay, fine. Proceed, please.
Corneal reflex present on both the side. Conjunctival is intact. Then pectoral reflex is absent. Abdominal reflex is absent. Cremastic reflex is absent. Plantar is mute. Bulbocavernous absent. Anal reflex is absent. Anal tone is reduced. Beaver sign is absent.
So anal
Deep
reflex, can you tell about the
Sir, can you tell? Sir, you're not audible, sir. Sir?
am I audible?
Sir, not audible. Yes, sir, yes, sir.
Okay, proceed.
Proceed, okay. Deep
Maybe my
tendon
connection
reflexes.
problem is there. You proceed.
Georgia, it's not exaggerated. Biceps absent. Inverted biceps present. Triceps exaggerated. Inverted supinata present. Knee reflex and ankle reflex is absent.
Okay.
Sensory system. Spinothalamic tract. Below C5 level. Crude touch, pain and temperature. Absent on the right
What
and
is
left.
inverted supination? Inverted supination, if it is present, where will you localize the lesion?
At the level of C5, sir.
What is inverted supination?
Sir, inverted supination, instead of flexion of the elbow, there will be flexion of the fingers, sir.
Okay. What is inverted triceps?
Inverted
Or
triceps,
inverted-
instead of extension of the elbow, there will be flexion of the fingers, sir.
Flexion of the fingers. Inverted biceps is if you put that
No,
biceps,
sir, there will
tricep
be
flexion
flexion
will
of
be there.
the elbow.
Okay, flexion of that. Okay, fine.
Elbow, sir. Yes.
Okay.
Posterior column.
Okay, proceed.
Sir?
Proceed.
Sir?
Can you proceed?
Below
Yes.
C. Fine touch vibration positions in absent on the right and left. Romberg's test not able to assess. Cortical sensation, since the primary modality of sensation is absent, it is not assessed. Cerebellum and gait, dysdiadokinesia able to perform. Finger nose and finger nose test present. Rebound phenomenon absent. Heel shin test not able to perform. Intentional tremor negative. Titubation and nystagmus absent. Gait not able to assess. Autonomic nervous system. Sir?
1 minute, Sangeeta. Finger nose and finger nose, you were able to demonstrate in this patient because power was 4 minus by 5.
Yes, sir. Yes, sir. He was able to do with some difficulty, but he was able to perform, sir.
Okay, fine.
Autonomic nervous system, postural hypertension, not present, no excessive sweating, resting tachycardia absent. Extrapyramidal system, no resting tremors, athetosis or chorea. Meningeal signs absent, spine normal, no gibbous deformity, kyphosis or scoliosis. Vibration over the spine below C5 absent, cranium normal, no brewing in the back, no peripheral thickening, renal sign is negative. Other system examination, cardiovascular system, first hearts and second hearts and here, there was no murmur. Respiratory system, bilateral air entry, present, no added sounds. Per abdomen soft, non-tender, bowel sounds present, no organomegaly. Diagnosis, since this patient has two level of involvement of the lesion, sir, I would like to tell the diagnosis as cervical involvement and lumbar. The structures involved in cervical is bilateral corticospinal tract, spinothalamic and posterior column. Etiology, probably degenerative spondylitic myelopathy, extramedullary extradural, And the lumbar, the structures involved a cauda equina, autonomous bladder with bowel involvement because of post-traumatic compressions.
So how to differentiate between extradural, intradural, and extradural, intradural, and extramedullary, intradural? Three things.
Sir,
How will you differentiate?
extradural and extramedullary and intramedullary, the root pain will be predominant in extramedullary, sir, and the pain will be sharp. Then in intramedullary, the
Extramedullary
pain
or
will
extradural?
sir, extramedullary, extradural, sir.
Okay, okay.
And vertebral tenderness, ethanol will be present in extramedullary, sir. Then in intramedullary, the
Extradural,
pain will be
extradural.
follicular.
You tell about the extradural. Just tell about extradural. Once you tell about extradural, it is always extramedullary. So if it is
Okay, sir.
extradural things, what you told of radicular pains will be there, and if there is a vertebral body tenderness will be there. Usually in extradural, if that injury is not that severe enough, it will cause some asymmetrical kind of weakness can be present.
Okay, sir. Okay, sir.
Okay.
Usually
If it is a
intradural, it will be
intramedullary,
asymmetric.
okay,
Intramedullary,
intradural.
more like element type will be there, sir.
Okay.
Descending involvement will be there, sir. Fibers.
Regarding bladder involvement is common in
Early
intramedullary.
bladder
Early bladder will
involvement
be.
in case of intramedullary, sir. Sacral sparing will be present in intramedullary, whereas sacral will be involved in
Okay.
extramedullary.
How will you tell
Then
that
descending,
arrangement of fibers, spinal fibers, all tracks are there, no? Arrangement of tracks from medial to lateral in posterior column.
sir, in posterior column alone, it will be like SLTC, sir, sacral, lumbar, and thoracic and cervical. In all other areas, it will be cervical, thoracic, followed by lumbar and sacral, sir. CTLS.
Okay, fine. From medial to lateral. Okay.
From medial to lateral, sir.
That's why the patient
The
is having
sacral
that
sparing is
sacral
present
sparing and sacral
sparing in
involvement.
intramedullary. Yes, sir.
Yeah. Yeah, fine.
So the anatomical level is motor level below C2 and above C5 level. Sensory level is at C5 level. Reflex level at the level of C5.
And one more question is, what is the difference between cauda equina and conus lesion? And what is mean by conus? How will be the patient in conus lesion?
Sir, conus means the involvement is S2, S3, S4 level, sir. And the patient will be having saddle anesthesia in conus medullaris. Cauda equina, it will be asymmetric, areflexic, sir. And pain will be more severe. And then this urinary retention will be more in cauda equina, sir.
Actually, conus is not actually S3, S4. It's the lower part of spinal cord. So it is S3, S4, S5 and coccyx.
I said,
Actually, it is
but
for the
cauda
conus.
starts from below L3 root and below, sir, up
Yeah.
to L3, L4, L5, S1, S2, S3.
Yeah. So if the patient is having a conus lesion, as the patient
Yes,
is
sir.
having only S3, S4 involvement, not only patient will be
Sir, your voice is breaking, sir.
involvement. And the patient will be having only bladder involvement mainly. Hello?
Sir, yes, sir, yes, sir. Bladder involvement?
In conus, patient will be walking
Yes.
and leaking.
Yes, sir. Walking and leaking in case. Yes, sir. Okay, sir.
Okay, you
In
proceed.
cauda, it will be. Okay, sir. Sir, investigation, patient baseline investigation. I will proceed with the investigation further, sir. Complete blood count, random blood sugar, viral markers, liver function test, urea and creatinine, serum electrolytes, serum B12 level, MRI brain, dorsal lumbar spine and whole spine screening, echo and NCA study, sir.
Okay.
So this is MRI section of the patient, sir. At the level of L1, L2,
Okay,
there is end plate destruction with collection, sir, involving the bilateral psoas muscle also, sir. So this is a report of the MRI
Okay.
dorsal spine. There is reversal of cervical lordosis, diffuse posterior disc bulge, noted indenting the anterior cord at C4, C5, C5, C6, and C6, C7 level. Antrolisthesis of L4 over L5 with posterior disc herniation, compressing the thecal sac and nerve roots with the severe spinal cord narrowing. Opposing end plate destruction of the L1, L2 vertebral bodies with peripherally enhancing collection in the intervertebral disc, extending into the bilateral paravertebral regions and psoas muscles. So after taking the MRI, we came to know that there is also another collection in the psoas muscle and the L1, L2 levels, sir, for which we subjected the patient through to CT guided biopsy. The sample was taken and it was sent for the culture and gene expect suspecting epidural abscess or any spine tuberculosis etiology to rule out. We sent for gene expert also, which was negative, sir. But the culture report came as Salmonella typhi. So patient was managed with the DVT prophylaxis, bladder catheterization, analgesics for pain. And since Salmonella typhi was present in the sample, the sensitivity was identified and we started on antibiotics, ceftriaxone and azithromycin. And we have planned to continue for 3 weeks, sir. And the procedure done is debridement with posterior stabilization and fixation at the level of L1, L4. Post-operatively, power was improved in both the lower limbs for the patient and patient got discharged.
Okay. Any other thing to be added on?
Sir?
Any other discussion or to be added on with this patient? Only ceftriaxone, azithromycin can be given, and how was the patient outcome after that?
Outcome is power has been improved, sir. Initially,
Okay.
patient had no fever spikes and also, so that constitutional symptoms was not present. But this collection, after starting antibiotics, power has been improved from 0 to 3, sir, in the lower limbs.
Okay. So now the patient is perfectly fine and there is no other weakness right now. Or?
Yes, sir. That upper limb weakness, it was the same, sir. Lower limb, it has been improved, sir.
Okay, fine. And bladder complaints also?
Bladder
Regarding the
complaints,
bladder, patient is still on catheter.
sir, till post-surgery was on catheterization, sir, but sensation is recovering, sir.
Okay, fine. Okay. Any other questions from the panelists? Sir?
Yeah. I think almost the basic parts as well as the important therapeutic points we discussed. Dr. Sangeeta Priya, do you have any doubts to be clarified with you, with Dr. Sanjo or Balakrishnan regarding this spinal cord case approach? Yes, touched upon the basic science also regarding the anatomical localization, including your placement of the fibers or order of placement of the fibers, and how
Yes,
the
sir.
involvement, how to approach extradural, intradural, those type of commonly expected questions for the any spinal cord disease.
Okay,
Anything
sir.
else particularly you want to ask him about to clarify? Nothing?
Sir, no, sir.
Yeah. And Dr. Sanjay, would you like to give any input regarding the quality of presentation? Anything from exam point of view, MD, postgraduate, anything else you wants to improve?
Sir, the presentation is good. Sangeeta has done a good part, but the patient is having the lesion at the multiple level. That is the one confounding thing. The thing is, one, the history was not correct from the patient side. From the patient was having that cervical and spondylotic changes with some myelopathy changes was there initially itself. And after that only the patient was having that slip and fall, and the patient was, we are attributing to that 2 lesions actually. So if the one lesion, that is also the thing is the power and reflex and tone, it is not correlating correctly between the upper limb and regarding the UMN lesion and LMN lesion. So we'll have to get a clarification from the examination point of view, and the history is also lacking from the some history was lacking, and the patient was having multiple involvement at the multiple cord levels. So that has to be clarified. And the
Okay, sir.
patient's examination also has to be regarding that UMN pattern of weakness has to be examined correctly for this patient, because the patient, as you are telling about corticospinal tract, the patient
Yes,
was
sir.
having that not that pattern of weakness was not being followed in this patient. So the patient was having both extensor and flexor weakness, both are of the same 4 minus by 5, and there is no that much you told about the tone is increased, whether it is passively or rigidity, and that has to be clarified correctly.
Clarify.
And
Okay, sir.
yeah, and regarding the reflexes you told about and all these things, and LMN weakness can be whether it is because of that spinal shock or cornus cauda lesion, also has to be both are possible for this patient, whether it is in a purely
Yes, sir.
LMN lesion for a patient presented with a paraplegia with a spinal cord involvement with a background history of diabetes. So whether it is a
Yes, sir.
purely, the thing is whether it is an LMN, first we have to tell is there is a lesion, and after that whether it is a LMN bar UMN. As the patient is having
Okay, sir.
multiple type of lesion is present for the patient. So
Yes, sir.
first is a UMN pattern, and now you're pointing towards an LMN pattern. So the thing is
Yes, sir.
having multiple lesion is present for the patient. So
Okay,
once
sir.
if you are putting into a single lesion at cervical level, and the thing
Yes,
is
sir.
vibration also you told of decreased from C5 level. So if it
Yes,
is a
sir.
different level and once it is improving, the other is not improving, and once one it is in a long standing illness and the other is a now the slip and fall with a lump,
Sir, can
if
if
it
it is
present for
if
the
it
patient, that
sir if is the known diabetic, sir. Hello,
okay.
sir.
You tell me.
Known diabetic
Am I
can move for
audible?
more than 50. Sir, you're audible, sir.
Okay,
Sir,
okay.
known diabetic and the possibility of peripheral neuropathy.
You can tell, but the thing is, you told of upper limb spasticity is present for the patient, no?
Okay,
And the
sir.
patient is having some thinning was present for the patient, and some it is not symmetrical in the upper limb, no? And you told about that picture, and
Yes, sir.
I couldn't find it as a symmetrical, and the patient was having more thinning was present in the upper limb, and spasticity was also you pointed towards upper limb. And if it is only the peripheral neuropathy, why that spinal vibration got decreased from C5 level? So that is also
Okay, sir.
not pointing towards that. If it is a peripheral neuropathy, spinal vibration will be normal. If it is a
Okay, sir.
posterior column, if it is affected only, spinal vibration will be affected.
Final solution. Yes, sir.
Yeah. And bladder can be present as kind of diabetic also, but the thing is, spinal
Yes, sir.
vibration is not correlating in this patient.
Okay, sir.
Dr. Singh, we will understand the findings, whatever you told,
Yes, sir.
the arriving at the differential sites of the involvement is not matching. Okay, it's
Okay,
a
sir.
bit of tricky to find out and localize and put the lesions under one roof is a bit of difficult from this
Yes,
findings
sir.
what you have told. So that's the basic point already we discussed about also. So it's not matching each other. Okay. So probably it's a
Okay,
high time for you to just go back and start reading about the classical features of individual structures, whatever is involved as mentioned by you,
yes,
and
sir.
try to correlate with the signs and try to understand and list out what are the signs, positive signs in this patient, and try to
Okay,
read
sir.
about that and try to correlate. That makes
Okay,
your
sir.
this exercise will make your understanding of neurological case approach, especially spinal cord disease, at different
Yes, sir.
levels, how to explain the clinical signs, and what are the additional structures can be put into or involved or bring into the discussion to say that explaining this additional signs, whatever is happening. For example, you have a LMN as well as UMN.
You.
If you are having a classical UMN signs alone with a diagnosis, that means you are somewhere wrong. That you are mentioning about signs of element which you have missed out.
Okay,
So in
sir.
that case, you need to bring in some explanation for element signs in a person who is having major UMN signs expected.
Okay, sir.
I hope you are understanding what I'm trying to say. A bit
Yes, sir.
of confusion might be there, but two signs or two, three different structures involvement signs which is not anticipated, but still you
Yes, sir.
have those signs. You need to try to understand how to offer the explanation in that patient.
Okay, sir.
for explaining the involvement of different structures, which is not really expected. Okay. That's a
Okay,
basic
sir.
point. It's a high time for just go, because today it should go back and start learning about whatever the points taught by Dr. Sanju to make you
Yes,
to
sir.
understand better, and repeatedly read. That makes your answering capacity much better during the examination day. Okay.
Okay, sir. Okay,
Yeah,
sir.
yeah.
Thank
I
you, sir.
think much of further discussion can be closed this session, Dr. Sanju.
Yes, sir. Sure, sir. Sure, sir.
Yeah. I really thank you, Dr. Sanju and Dr. Balakrishnan, for wonderful discussion. Really appreciate Dr. Sangeeta Priya for wonderful presentation. Thank you and good night, all of you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.